disease topic, hypertension. And I happen to know that our group is on the list to receive a request for proposal. There's money that's involved. I have no idea how much or what it's going to involve. But that's part of the reason why it's kind of a, self-serving for some respect, but it'll be a much more practical.
Let's do more of that.
I'm into self-serving.
Yeah. So I think the way we had structured this is part of it's going to be, we'll talk about the JMC7, which Mike's going to talk about. Talk about some of the stuff that I had found in the literature about what's known about managing and improving hypertension in an office setting. And then what are the things that we really have to think about if we want to gear up to do that? And Brian's got some of that stuff. So Mike, if you want to kind of just give an overview of how's it going on?
Just recording it now.
Is it recording at all?
Yeah, it's just when you lean back and not really.
Okay, all right, so I'm
It's perfect.
it's perfect. So
Just
Mike's
the way
going to
we
kind of
like it.
review the JNC 7.
Good. So as you may remember, it came out in December of '03, and usually they come out every 6 or 7 years. So anticipate that we'll actually probably have some new consensus data coming out probably in the next 1 to 2 years. And the JNC7 was an academically thoughtful group of people that were challenged by Claude L'Enfant, the chairman of the Heart and Lung Institute, to try to make their recommendations much more practical, much more available and implementable than the previous JNCs had been. You may have remembered they'd have 9 stages of blood pressure, and you couldn't understand anything. And this was meant to be much more bare bones, more directed. And the four tenets of driving this one home was about prevention, the detection of blood pressure, how actually should it be evaluated in an ambulatory setting, and then a fair amount of treatment options that were at least available and felt to be supported by evidence in December of '03. The big things that were kind of brought into this were any new data that had come up over the last 6 or 7 years. As I said, a much more effort to be very clear and concise about just what the guidelines were. And then finally to try to simplify classification down from 9 levels of blood pressure to then 4. This is a 1-page front and back issue that you can almost read along. As I go through kind of the topics of things, that you'll almost see that it incorporates them perfectly. The big issues about classification of blood pressure were, by their definitions, that you should have two readings at every visit. In average, they should be 5 minutes after visit. They actually suggested in the body of it, it should be when someone is sitting with their arm on a table and, quote, not on an exam table. And then actually suggested that you should have a second set of average data at some other point in time before you talked at all about status of blood pressure. The most important issue was classification. Normal was felt to be less than 120 and less than 80. Pre-hypertension was rather broad, 120 to 139, and diastolic 80 to 89. Stage 1, 140 to 159, 90 to 99. Stage 2 was greater than 160 and greater than 100. The point that they bring out is all of those, the reason they stratified it that way was, number one, some issues about specifics of intervention that we'll talk about, but also the risk factors. And one of the dominant issues about blood pressure that they wanted to bring out, and I still think isn't very well understood. Number one, very dominant, the systolic blood pressure is the key. It's not diastolic blood pressure. And that as you age greater than 55, the incidence of blood pressure just is, it's hockey puck, how graduated it is. They actually pointed out that of the people that are greater than 50, at age 55, if you are normotensive, you still have a 90% chance of becoming truly hypertensive in your life. It's just,
It's a given.
it essentially is a given. I like your glasses.
Thank you. Shut up.
Okay.
They make you look like Howard.
Like who? Like what?
Howard. I was thinking of Whitmer.
Alan? Careful, I may scar you so you look like McCain.
If somebody is stage 1 or stage 2 blood pressure, they actually did
This is
suggest
going on the tube.
a fair number of laboratory and diagnostic tests that I actually was a little surprised at. And they list actually 8 items that they suggest, including cardiogram, obviously looking for endo disease.
At
It
the
is
time
on
of
the foot.
diagnosis or at the time the first elevated blood pressure is detected?
Yes, before intervention with medicine.
Even though that's not
Before-
paid for.
Right, before interventions for medicine.
Is that on the
Cardiogram, but it is on there somewhere, I believe. They have to look. And yes, is that everyone looking?
Oh, there it is,
I think they are all listed there.
in the
there they
left-hand
are.
side.
Yeah. So EKG, blood glucose, hematocrit, potassium, creatinine, calcium, lipid profile for mixed risk factors, and possibly a urine albumin, which I was a titch surprised at.
That's surprising, too.
Before you.
And again, they point out the goal in somebody who has no other comorbid risk factors was at this time just under 140 and under 90. If you had comorbidity, which they only then described as cardiovascular disease, they kind of suggested but didn't actually state diabetes and renal disease, they would say goal is 130 and 80 on that.
This is to make it less confusing, right?
Well, that's not bad. One of the surprising things was follow-up and monitoring that I had forgotten from the original. They suggest monthly intervals of monitoring of blood pressure as you're instituting treatments. More frequent if somebody is stage 2, that is greater than 160. More frequent than once a month. That you should be
Forever and ever.
monitoring them initially,
No, that's
until you
Until
gain
they come down.
control. They suggest after someone's gained control, review it 3 to 6 months, but more frequent if somebody has comorbid disease. So it's actually suggesting fair frequency. Suggest a potassium creatinine, no matter what treatment you're doing, once or twice a year. I didn't quite understand that. Through in low-dose aspirin at some point. They only and they formally describe resistant hypertension as failure to meet goal with either comorbid or plain when somebody is on 3 drugs. Some of the other big things that you'll notice in here that are rather strongly commented on that I have forgotten. Number 1, thiazide should be first line at that time. Most patients who have blood pressures, actually most patients will require 2 drugs or more. The belief that you're going to get away with 1 drug, they fairly poo-pooed. They also pointed out, and specifically, if anyone is systolic 20, diastolic 10 over your goal, you almost are assured at the beginning that you should start them on 2 drugs.
At the beginning.
At the
That's
beginning.
the,
It's like one of those combo even.
And I think, and then that 1-page summary kind of shows that as mastered. So that's the background as of JNC December of '03.
So what I did was I was looking at it from the point of view as like and at some of the articles I have that kind of reflect that. How do you actually try to improve your management of blood pressure in the office so you can meet some of these NCQA accreditations and medical home and reduce variation in healthcare? So the first one of the articles there was one that says how are we doing or something like that. How will we managing and monitoring high blood pressure? And it's by Pavlik et al. And it basically kind of reviews, and this is an older one. This was probably around the same time that the JNC7 came out, 2003 when it came out. In managed care organizations, only 50% of patients are at goal. In the U.S. in general, it's about 25 to 30% are at goal that know they're hypertensive. It's even lower for all hypertensive. In Europe, I was surprised it's 15%. It's worse than us. I'm kind of surprised at that.
it's all that pot tea.
I don't know what it is. The biggest reason they found in kind of reviewing literature for poor control was MD tolerance of a higher blood pressure. They said that most docs are willing to tolerate a higher blood pressure. They don't feel as concerned as I guess the policy wants about blood pressure. The other thing they mentioned is that the way of taking blood pressures that we typically do with